Our final presenter this afternoon is Michelle Coe. Michelle Coe is Canada's most academically accomplished physiotherapist and clinician-scientist in critical care, a leading thinker in rehabilitation science. Following critical illness, she has made novel scientific contributions with global impact. Dr. Coe has spearheaded ambitious international clinical trials and advanced new rehabilitation research methods to improve the recovery of critical illness survivors. Committed to excellence in clinical scholarship, her methodological expertise informs national and international practice guidelines. Welcome, Michelle.
Hi there, and thank you very much for this opportunity to share a bit about our research, and congratulations to the new fellows and new members of the college. This is an overview of some of the work that we've been working on for the last 10 years, and I'd like to highlight that I am presenting this work on behalf of a whole group of people, particularly on behalf of the Canadian Critical Care Trials Group. Our research has occurred in 3 different countries, in Canada, including Ontario and in Quebec, and in the United States and in Australia. So I'm an ICU physiotherapist, and this is the environment in which I work. And you can see here, we have a person who requires a breathing machine or mechanical ventilation in order to stay alive. You can also see that this person's monitored and also is receiving drugs to stay alive. And when we're working with critically ill patients, patients in the ICU are some of the sickest patients in the hospital. 80% of patients will survive their ICU stay. And it's important for us to think about what happens after an ICU stay. And this is a quote by Professor Cheryl Mizak, who is one of us. She's a professor of philosophy at the University of Toronto, and she survived an ICU stay. And I'd like to highlight what it was like for her to survive in her own words, in that she experienced important weakness and fatigue. And as a physiotherapist, I know that people are going to need rehabilitation. So my goal is to try to see how quickly and safely we can start rehabilitation for these people. This is an example of the technology that we've been recently studying in our ICU. And you can see here a physiotherapy assistant using a specialized in-bed cycle with a simulated patient on mechanical ventilation. Here, the bike has a motor. It can move the patient's legs for them. But when a patient is able to, they can start to contribute to moving the pedals themselves. So this helps give patients more control and more dignity over their recovery. So you saw the title of our research program. It's called Cycle. And really what we've tried to do over the last few years is show that it is possible to do this research with this very complex population and a very complex environment. We started off with a single center study. We then showed that we could do this complex intervention in multiple centers in Canada. We recently completed a multi-center randomized trial in 17 centers and 360 patients. If you're interested in learning more about our randomized trial, we have a QR code up here so you can learn more about the details. I'm going to give you the Coles Notes version. We enrolled 360 patients across 16 centers who were able to recruit patients. Patients were randomized to either early in-bed cycling, 5 days a week, and usual physiotherapy, or usual physiotherapy alone. Our primary outcome was a functional test to see how well people could move. And when you design clinical trials, you want to show your effects on one outcome. This PFIT test shows that higher numbers represent better values and therefore better function. And while you can see here that the PFIT had higher scores, unfortunately they were not statistically significant than the comparison group, which obviously was disappointing for our group. However, what happens if we add our research to other in-bed cycling studies around the world? And this is a paper that was led by one of my trainees. Cycle was the largest randomized trial of early in-bed cycling in the world. But you can see there are other places around the world who also studied in-bed cycling. And what did we find? Well, over 33 studies and almost 3,300 patients, if you include in-bed cycling as a part of ICU rehab, patients will have better function, there'll be a shorter ICU length of stay, and 1.5 days shorter hospital length of stay, and it was safe. But what does this mean? Patients can get a head start on their recovery. They can leave hospital sooner, and it can be safely incorporated into ICU rehabilitation. I invite you to look at our QR code to read more about our systematic review, and I'm thankful for the opportunity to share more about our work.